Okay, let it begin. Thank you so much, Dr. Bush, for agreeing to make a presentation to our group tonight. We greatly appreciate you doing this. We will be recording this session, so if you don't want your image on this recording, please turn your video off now. We plan to share this with the rest of our group.
It did a pop-up that warned everybody, I think.
Okay, perfect. It should. So, Dr. Bush, I would like to ask Ankush Bansal to please introduce our guest, Dr. Bush, who will be presenting to us tonight. After his presentation is finished, we will have a 30-minute question and answer period. I ask that everybody submit their questions to the chat panel, and I hope that you all understand you can hit that icon that says chat and it opens the panel, and you can type in your question either to me personally or to the entire group, preferably the entire group so we don't have redundant questions. And with that, I will turn it over to Ankush to introduce our guests and proceed with the presentation. Thank you very much.
Thank you.
Thank you, Cindy. Welcome, everybody. Dr. Larry Bush is a nationally recognized infectious disease expert and physician in Palm Beach County, Florida. He received his medical degree in 1982 from the Medical College of Pennsylvania. He then completed his internal medicine training at the University of Pennsylvania and his infectious disease training at the Medical College of Pennsylvania. He has been an educator in medicine since 1983 and in leadership positions since 1984. He currently practices and serves on committees at Wellington Regional and JFK Medical Centers. Dr. Bush is the current president of the Palm Beach County Medical Society. He has received numerous awards for his clinical and teaching excellence here in South Florida. He is an author of almost 100 scientific articles, 25 textbook chapters, and the principal investigator of almost 75 clinical research trials since 1986. Back in 2001, Dr. Bush made the very first anthrax diagnosis in the nation following the attacks of 9/11. He has been sought after by local, state, and national media this year during the COVID-19 pandemic and a regular expert to the Florida Medical Association. We are honored today to have Dr. Bush give us an update on the current pandemic and his predictions for the future. Dr. Bush.
Oh, thank you. That's so kind of you. That was very nice. And thank you for asking me to join and to give a brief presentation. Obviously, we're going to talk about COVID, a little bit about pandemics beforehand. So thank you so much. I'm going to put this on share my screen, and what we're going to see, hopefully. Does that come up okay?
Perfect.
Yeah.
Perfect.
Okay. All right, so this is going to be a little bit talk on COVID, but before we get on COVID, what I'm going to really aim on a little bit is other pandemics. So in emerging infectious diseases, which is what I do, I'm an infectious disease specialist, as Ankush just said, it really comes down to three driving forces, some of which we have control over, some of which we don't. For instance, we have the pathogen, the host, and the environment. And I think, as we'll probably hear at the end of this talk, is that what we're dealing right now with is the host, meaning us. And are we having people who are just not taking it seriously enough or have forgotten what's going on? Because we're not going to affect the pathogen that well. And it's pretty difficult to affect the environment at this time. So just a little primer on emerging infectious diseases. Emerging infectious diseases are those that have been newly appeared in a population, either globally or regionally. And re-emerging diseases are those that have been here before and have reappeared once again. And we're warned when these are coming and what's going on new or what's coming on old and coming back by both the World Health Organization and the CDC. Now, obviously, there's a lot of discussion about the World Health Organization and the CDC, who's doing what's right, who's doing what's wrong. I can tell you, the person I trained under for infectious diseases also trained Anthony Fauci, so I've met him several times. And regardless of what anybody feels he's saying is right or wrong, the truth is he has no axe to grind. He's saying what he really believes academically, what he can't predict the future, obviously. But I don't have any problem with him. As far as the World Health Organization, I can't comment on them. Obviously, that's a political organization to some degree, and not everybody who's involved necessarily has as much knowledge as some of the folks at the CDC. But having said that, this is where our information tends to come from these days. So if you look at emerging infectious diseases, just since 1973, we're talking about, you know, almost 50 years, you can see as I go through this list, a lot of these diseases that once before were so high in the news have been forgotten about now, or we just take them for granted. Let's take, for instance, E. coli O157H7. That's the one you hear about, tainted hamburger, for example, that causes what we call a hemolytic uremic syndrome. Lyme disease, first identified in 1982. You know, back then it was a real big deal. It's still a real big deal, but it sort of has taken a back burner. Legionella, 1977. I was in Philadelphia, it's where I'm from, at the time when all that was going on. So in 1983, HIV, the most devastating epidemic that's ever gone on in history, sort of is something we live with these day and age, and just take it for granted in a lot of ways. So, well, for some reason, my sharing went off. Okay. Let me just put this back on. I'm sorry. All right. All right, I'll do it this way. Okay, sorry for that. All right, so when you look at some of the examples of the emerging and re-emerging diseases, actually this comes from Anthony Fauci himself, you can see by the arrows in the red and the blue and the black what's gone on around the world. And if I could put my cursor right here, you can see, as Anka said, the first case of bioterrorism was right down here in our backyard in Boca Raton. So we're not immune to having emerging and re-emerging infectious diseases. That's gone on throughout our history. When you look at the leading infectious disease killers, both in the United States and the world, it's always been respiratory diseases. And the reason for that is the large bar on the left is because respiratory diseases are transmitted without much you can do about it unless you totally avoid being around people. Factors for emerging and re-emerging infectious diseases are a little bit complex, but they really are ecological changes in agricultural development. Let's take, for instance, Lyme disease. When we started reforesting the United States, we had an increased number of deer and deer ticks. Deers are the reservoir hosts, or the ticks are, for the Lyme disease. The particular deer tick is going to be where you have these particular deer, and it increases human contact when we started moving into the neighborhoods where it's nice to live in a wooded area, and therefore all of a sudden we have Lyme disease, which didn't suddenly emerge, but became recognized. There's also changes in human demographics and behavior. We're going to talk about inflation of the size of the population, but also about globalization and travel. So these are some of the human demographics and behaviors that affect emerging diseases. Now, I think this slide, and I use this in a lot of talks, is amazing. Look at 1980 or so, right there between 70 and 90, and look at how many people were living in the world. Approximately 4.2 billion. Bring that ahead to 2020, where we have now approximately 8 billion people in the world. The world population has doubled since the time Ronald Reagan was president. I can tell you from the first year AC, until 1827, that's how much time it took to grow from 100 million people to 1 billion. We've doubled from 4 billion to 8 billion in the last time since Ronald Reagan was president. Besides that, look at where the growth of the world is. It's in less developed regions. Therefore, sanitation, vaccinations, et cetera, are obviously not the same in the developed world, which is not growing as fast. Here's a statistic that always amazed me. Right now, approximately 8% of anybody who's ever walked on the planet Earth is alive right now. To me, that is such an amazing number. So when you look at international commerce and travel, this is the major reason why we have emerging and re-emerging diseases. This just goes up to 2005, but it tells you the US residents who travel abroad and how that number is huge. For instance, if you look at 2015, approximately 1.2 billion international tourists arrived. In 2018, that almost doubled to 2 billion. You can see where most of these people are going, and you can see that a small amount of them are having immune-compromised conditions or on medications that harm our immune systems, but that's growing as people live longer, and we have different type of medications. And only 40%, approximately less than one half of the people who travel go for any particular advice or vaccination. This is the number average of global airline passengers just between 50 and 2010, and you can see where that's grown. We're a decade from there. And this is the commercial air traffic over a 24-hour period. This is my second favorite slide. If you look at this next slide, find a place on the global air network where a plane is not taking off or landing every day. So having said that, why are we shocked that a novel coronavirus somehow got into the United States? My question is, what takes some of these things so long, not why it happened. These are the areas where most of the population of the world is traveling on any one year. And these are the countries where Americans tended to travel 5 years ago to greatest numbers. Mexico, Canada, United Kingdom, Japan, China, some parts of the Caribbean, and then you get into Germany, Brazil, India, Italy, and other countries. What's even an amazing number when you talk about social distancing is this is the predicted amount of people going to these events between 2019 and 2022. Well, obviously there's going to be a change because this was put up there before COVID. But if you just look at, for instance, religious events, look how many people are protected or projected to attend. Go down to any of those religious events and see how many sporting events between the Olympics and the the World Soccer League. Look how many people go. Look how many people even go just for art and music festivals. So the major factors contributing to the emergence of infectious disease are human demographics, behavior, technology, economics, travel, the adaptation of the microbes. The microbes on the planet Earth outweigh the human population by a factor of 33 billion to 1. I mean, they're not gone away. And as long as we get into their face, they're going to affect us because they're not gone away. So let's talk about pandemics. So what is a pandemic? A pandemic is an epidemic that is spread globally. Epi, upon, meaning upon, demic, meaning the people, pan, all over, demic, meaning all over, all the people. And we've had multiple pandemics. If you look at this slide here, you can see that, yes, we're dealing with coronavirus right now, but the world has dealt with pandemics historically in huge numbers since the beginning of time. Ring around the rosy, pocket full of posy really referred to the Black Plague back here. 75 million people died. Smallpox, 300 million people died. The Spanish flu, we're going to talk about, 50 to 100 million people have died. Measles, 200 million people, excuse me, I'm talking quickly, have expired from measles during these epidemics, and we still have people feel that taking the measles vaccine is not a good thing for you. So pandemics have been around, they're always going to be around, but when we talk about pandemics, we seem to always be talking about respiratory diseases, or recently Ebola, but we're also talking about the flu mostly. So the history of the flu really goes back to 412 BC, and in 1580, the first pandemic was actually described. Between 1580 and 1900, there were 28 pandemics described, but remember, there wasn't a way to actually describe them as easily as there is now. Influenza, I don't know if you're aware of this, you all hear about influenza type A, type B, but there's also a type C that we don't even vaccinate against because it's very benign. And most of the pandemics, or all of the pandemics for influenza, have to deal with type A. So what is it? What's so special about influenza? Well, besides being a respiratory tract disease, it has the ability to be something that has a changeability very, very easily. And that's really a problem when you're talking about a respiratory pandemic. Let me give you an example. We classify influenza by two of the surface proteins, one called hemagglutinin, which is the H, and another one called neuraminidase, which is the N. Humans have only been infected by H123N12. Well, you could do the math. Look at the permutations you could do here between 17 H's and 10 N's. It's endless. That's why when we talk about so-called bird flu, we get all worried that there's a bird flu. Well, let me just inform you that all influenzas are bird influenzas. Not one isn't. It goes from birds to mixing animals that we call pigs to humans, to horses, to aquatic mammals, to dogs, to cats. So as long as you can mix these viruses, these different viruses of influenza in different animals that can now adapt to infecting us, you'll have a new influenza. So if you look at the history of pandemics, which is really a flu pandemic, it's really A, because that's more virulent. And pandemics with influenza, I'm going to show you, have caused a lot of havoc in the world. So what causes this? Well, what causes it is that the influenza A has the ability to change. And when it changes over time, you can see that we go from swine flu to avian flu. As I said, they're all avian flus. And we get a mixture of new A's that we have no immunity to. And when that new A doesn't just drift, but shifts, we have no immunity and we're in for a big deal. So how does that work? A human virus gets combined with a non-human virus from a bird in a mixing animal. They reassort the genes of the virus, and then all of a sudden we get infected. And when that happens, we get outbreaks. The biggest pandemic influenza outbreaks have been 1918, 1957, and 1968. I'm married to a Spaniard. She always takes a little offense when she hears about the Spanish flu because it's almost thought about like, well, the fault of the Spanish flu is the Spaniards. Well, actually, the difference is that the Spaniards were the first people in the world to recognize it. Then we had the 1957 Asian flu, the 68 Hong Kong flu. You can see how many global deaths there were. The reason why there were so many more global deaths back here is because medicine got advanced here. All of a sudden, we had ventilators, ICUs, antibiotics, and other things. Look at this slide here. This is the influenza 100 years ago, right? A century ago, we had a pandemic similar to what we have now. Look at the life expectancy in 1917, 1915. It was approximately 55. In 1 year, it dropped down to below 40. The life expectancy dropped this much because of the pandemic influenza at that time, which was called the Spanish flu. What killed them? Well, you see anything going on here? You see a ventilator, you see intravenous anything? This is basically what you had. You had a cot and somebody standing over it, and the military ran out of hospital beds, so they started doing this, and you can see, yes, they're wearing masks. Unfortunately, he doesn't have it over his nose very well. Schools and churches got turned into places where people were being hospitalized. People were being buried in mass graves because you didn't have enough time to dig single graves. So all of a sudden, people were wearing masks everywhere they went socially. 6 million people deaths from influenza just in this past 12 weeks in this area. You know, put that into perspective when you talk about the 119,000 people in the United States so far dying of COVID. Yeah, that's drastic, but just keep the numbers in mind here. And in fact, the hearse were lining up for funerals because there wasn't enough time. They were one after another after another. So then, what happened now? Well, we had vaccines, but unfortunately, if you look at how many people over 65 actually take a flu vaccine, it's less than 60%. That's terrible. If we had a COVID vaccine right now, how many people would actually get vaccinated? When people don't get vaccinated with the flu vaccine, and the reason they don't is because of this graph here. They say, well, I once got the flu vaccine and it wasn't very effective. And here's the effectiveness. Last year, it wasn't very effective. We don't have this year here yet, but it's about 47% effective. But effective doesn't mean you won't. It doesn't all just come down to whether you will get the flu or you won't get the flu. Effectiveness comes down to even if you get it, will you have a less severe disease? So what do we learn? It's in the red. This is unpredictable and it's going to happen over and over and over. So let's get to COVID virus. So all of a sudden we have a novel coronavirus in 2019 that we've named coronavirus COVID 2019. What do we know about it? What we know about it is that coronaviruses are not unique. In fact, these 4 coronaviruses are always endemic. They're always in our environment. In fact, they cause 1/3 of all colds that we as human beings get. Coronaviruses are large RNA viruses. They have some special features that we call that they have an envelope. Their greatest varieties in bats, and that's why bats can mix it with animals. And when animals and bats mix, and that's coronavirus, and they combine with a human coronavirus, we get a new novel coronavirus, just like flu, that we can become infected with. So the first one that we started seeing was defined as SARS, severe acute respiratory syndrome, which came on the scene in 2002 in Guangdong province, China. What was different about this? Well, bats were the natural host. Human and animal contact probably is what happened. It spread to about 12 countries or 37 countries. But fortunately, it got under control very quickly, and there were only a little bit more than 8,000 people infected, of which around 9% died. Now, why didn't this become what we have now? Two reasons. The Guangdong province of China is much smaller than Wuhan. And secondly, the politics were a little bit different in 2002 than they were now. Thirdly, because it got quarantined very quickly. Now, when coronaviruses cause a pandemic, two things count: how transmissible they are and how fatal they are. How transmissible they are depends on whether they're affecting the upper respiratory tract or the lower, because obviously upper respiratory tract diseases spread more easily than lower ones, because most people with lower respiratory tracts are in hospitals. That brings us to MERS, which was the second novel coronavirus. Middle East Respiratory Syndrome, because that's where it was, in Saudi Arabia. But this one, unlike SARS, most people wind up on a ventilator. Almost 40% of them died, but there were many fewer cases as of 2019. And then all of a sudden, we got a new one. So before we got a new one, what's interesting, in 2007, in a very respected infectious disease journal, the authors who were writing from Hong Kong actually said that the presence of a large reservoir of SARS-like viruses in bats, together with the culture of eating exotic mammals in southern China, is a time bomb. And there you go. 12 years later, in December, the New England Journal reports the first case of COVID-19 in China. It was just destined to happen. So we have a new coronavirus that we've named COVID-19. So in December 31st, the Chinese reported a cluster of pneumonia cases in Wuhan. Now, I know there's a lot of talk about, did it come out of the wet market? Did it come from somewhere else? How long did they know it? Well, they probably had to know, or at least there were cases being identified, whether they knew what it was or not, at least a few months before December. I would take it back until the fall, which means there was a lot of time for travel out of an area where 10 million people live to the rest of the world. Most of it first going to Europe. It was named SARS coronavirus 2 or COVID. There were 15 healthcare workers in the hospital. It was felt to have some hospital transmission, and then all of a sudden it went worldwide. Now, what are the symptoms? Well, 80% of people, as you know, who get infected with these viruses, even the novel ones, have minimal or no symptoms, mostly cold-like symptoms. There's no specific lab test. Very few of them get a secondary bacterial pneumonia, which is something we worry about with the flu. And you can see that the CAT scan turns out to be a much better test than the X-ray. I'm going to talk about that. This is a CAT scan. And for those who are not obviously used to looking at a CAT scan, here's the spine. This patient's lying on their back. Their head is going into their screen. Their feet are coming out of us. And the CAT scan is slicing them. So here you see slices through the lungs. This is the trachea, okay? And this is the heart, okay? Actually, it's a blood vessel. And this is the heart. When you compare that to a chest radiograph, you can see that you start to see infiltrates. Everywhere where it's dark should be very dark. That's where air is exchanged, the lungs. Here's obviously the heart. Here's the diaphragm. Here's the abdomen. But all this is inflammatory change. Now, what's interesting is this is not the virus causing this. This is your body's reaction to the virus in the lung, something we call the cytokine effect, that is damaging your lung. Here's another CT scan where you see a lot more infiltrates in this area where it should be very dark. Here's one that you start to see consolidation or confluence of this. Another chest radiograph that looks obviously worse. And here you start to see real severe disease in these lungs. And you can imagine why these people can no longer breathe and require a mechanical ventilator, because there's not enough lung tissue to exchange oxygen here. So what's doing this? It's your body's reaction to the virus. Any virus can do this. But this virus happens to attach very well in the lower respiratory tract. And your body's reaction to it occurs not just in your upper respiratory tract, but in your lower respiratory tract, which can be devastating when the reaction occurs. So then let's talk about testing. You know, people are using the word testing as if it's a panacea. When we look at tests, really, what is a test? A test is asking a question. And for instance, if you take an SAT test, you're asking a question to judge somebody's knowledge, assess their knowledge. In medicine, when we take a test, we're using it for 4 reasons: to make a diagnosis, to affect treatment, to control certain things of infection, and to prevent infection. So when we talk about coronavirus testing, you first have to ask the question, what good's the test going to do? Yes, you'll make a diagnosis. Will it help treatment? We don't have a good treatment or any treatment. Can you do infection control? Well, let me ask you this. Do you really need to know who's infected to do infection control? It does help, but you really don't have to know that. And prevention, the same thing. So testing. This is the rapid tester that you hear all about. This is the one that a lot of hospitals are using. It's rapid because within 15 minutes you get a test. This is a Q-tip type device that goes into the nasopharyngeal or the nasal cavity. It mixes it in a cartridge right here where it takes the RNA off of it, the gene off of the sample, and then you put it in here, and 15 minutes later it comes out and it tells you whether there is the gene for coronavirus 19 present in that sample. Here you see it in lifetime. And at Wellington, for instance, we have 5 of these machines going all day, every day, because everybody who walks in that ER or everybody who gets admitted or everybody who's going to have surgery has a test done. We'll talk about that when we get to the numbers. This is a little bit more sophisticated test called the GENEXPERT. What's different about this? It could run 16 tests at one time. It also looks for the gene or the RNA from the coronavirus. It uses a nasopharyngeal swab, except it's a little bit more sensitive than the one here. Now let's talk about sensitivity and specificity, which you probably know, but just as from the medical world. A sensitive test means it can detect what you're looking for. It doesn't necessarily mean what you're looking for is what actually you wanted to find. For instance, if I put one of us in a room and I put a blindfold on us and I fill the room with balls and I say, go in and get me tennis balls, and you have gloves on, for instance, thick gloves, you may be able to pick up a lot of balls, and some of them are tennis balls, some of them are rubber balls, some of them are baseballs. And when you come out, you can say, I brought you all the balls. So you had a very sensitive test. You can pick up all the balls. But the question is, are they truly the balls that I'm looking for? Tennis balls. Well, the ones that aren't means that you have false positives, which brings us to specificity. A test that's very specific means not only can you sense that those balls are there, but you're very good at selecting out which ones are tennis balls. So there's an issue here. This test can confuse other coronaviruses because it's very sensitive, but it's not necessarily all that specific. And what's wrong with that? That the lower the prevalence of a disease is in a community, the higher chance for false positives. Well, what's the prevalence of coronavirus in Florida? It's probably around 5%, which means that's a very low prevalence, which means that the specificity, how many will be falsely positive, hovers around 1/3, which means that every test that we see in the newspaper or on the news, or what I'm going to show you at the end of the talk here, doesn't necessarily mean that proves that's coronavirus. It means that we think it's coronavirus. It may not be. It may be a different coronavirus. This is a test that if you want to, you can order this from LabCorp for $119. I don't think they chose the number 19 by accident. And it's called a Pixel. And you can swab your own nose. You can put it in the test tube. You can mail it back to them with $119, and they'll give you an answer. This is just like doing a 23andMe test that people are using a lot for their genes. And what we're using in the hospital or what we're using in labs is the actual more sophisticated serology antibody test that LabCorp and Quest have also provided. Now, you've heard about rapid finger stick testing. There's a problem with that. Right now, the FDA has not approved any of these tests, any of the ones I've showed you, for diagnosis. What they have done is they've given an FDA EUA, meaning an emergent utilization acceptance, meaning we haven't put this through all the vetting we normally do for our tests or our drugs, but because of the situation that we're having right now, we're going to emergently recommend some of them based on the information we have. Now, these are rapid finger stick tests. Let me tell you how they work. you can see there's IgM, that's an early antibody, IgG, that's a later antibody, and control. Now, what we do is you take a finger stick or a drop of blood, you stick it in this well like you would for testing a glucose, you put a little buffer in there, and within 5 to 10 minutes, if there's coronavirus antibodies in that patient's blood, they will go up here by osmosis, and they'll attach to the impregnated antigens on this paper, and they'll give you a color test. IgM positive, IgG positive, control positive. What does that mean? That means that this patient, BJ, has coronavirus. Here's a negative one. The patient's negative, the control is positive. Well, what's wrong with this test? Well, first of all, the antigen being used in this strip of paper may not be totally accurate. Number two, the FDA has over 200 of these tests in front of them right now to vet. They've only vetted around 6 or 12 of them because their concern is that people are going to be falsely diagnosed or falsely excluded based on a non-sensitive and non-specific test. So here's our clinically available COVID-19 tests. We hear about testing. We have laboratory PCR tests, the ones I showed you with those machines. If you do it during the screening time and the patient's asymptomatic, you can't really tell whether they've been exposed and it's just too early. If you do it when they have symptomatic disease, that is our gold standard. If you do it for screening, shedding, convalescent phase, here's the problem. Just because you still carry PCR positive or RNA or the gene 2, 3, 4 weeks or even months after you've been diagnosed, it doesn't mean you have viable virus, and it does not mean that you're contagious. So people say, well, let's keep testing them until they're negative. Well, you know what? That's why the hospital census of coronavirus is going up, because the elderly people in every one of these hospitals who would be going back to a nursing home cannot go back to a nursing home, because the rules in the nursing home, and I don't disagree with it, are that until you have 2 negative tests, you can't come back. Well, that can linger for a long time. How about the antibodies? The problem with the antibodies are the false negatives, the false positives, and when you become positive and when you don't become positive any longer. And the other problem with that is just because you have antibody doesn't necessarily you'll be immune. I mean, the presumption is you will, but for many infectious diseases, when you have antibody, you're not immune. For instance, you can get reinfected with syphilis, you can get reinfected with Lyme disease. So what are the statistics? Where are we today? Well, this is 4 hours ago. And if you go on the Department of Health dashboard, and I tend to think they're honest. Why do I say that? Because I'm good friends with Alina Alonso, who you know is the Palm Beach County Director of Health, or Palm Beach County Health Department Director. And I know she looks at this data. I know that people in Tallahassee look at this data. And yeah, the numbers may not be extremely 100%, but they're pretty right on. So as of 2 o'clock this afternoon, this is Florida, up here where it says state, there were 93,797,000 cases of coronavirus diagnosed in Florida from the beginning. Out of that, almost all are Florida residents, some aren't. Out of that, 12,000 people have been hospitalized. We'll talk about that percent in a minute. And 3,144 people have died. That's about 5% mortality. Now remember, the mortality is based on how many people we've tested. But you don't know how many people we haven't tested who have coronavirus and therefore have never come to be known, and therefore you can't really count them in the deaths, because the mortality rate is the number of total cases divided by the number of the number of deaths divided by the number of total cases, and our denominator can only be people who have been tested. I won't ask you, but how many people on this Zoom right now have been tested? How many people in your workplace or people you know of your relatives have been tested? Probably less than 10% of the 23 million people who live in Florida have been tested. Therefore, it's usual that the sicker people get tested, not just the curious, but the sicker people get tested, and therefore that's going to increase the mortality rate. When all is said and done, Anthony Fauci is on the record in the New England Journal of Medicine of having said that he thinks at the end of the day, when we really know how many people in this country by antibody testing have had coronavirus, that the mortality rate will be around less than 1%, which is typical of influenza. Now look over here. Here's what you're hearing in the news. Look at the new cases of residents by day. Well, obviously, since these social distancing started to get closer and people started going back to restaurants and workplaces started opening, et cetera, the number has risen. And that's a concern. Now you could say, should we close everything down, or has this happened because human nature is people have a short memory? And what happened here is that people took their foot off the pedal and may not be distancing and doing the smart things, the simple smart things, like wearing a mask, washing your hands, staying away from big crowds, etc. And that's why this number is a little bit scary. Let's look at Palm Beach County. This is as of 2 o'clock this afternoon. As of 2 o'clock this afternoon, there have been about 10,300 cases diagnosed in Palm Beach County. About 1,551 have been hospitalized. About 468 deaths, that's around 5.3%. And here's the people who are positive who are non-residents. Again, look at the new cases by day. In the past few days or past few weeks, you can see the number rising. Now, why is that? Does that mean we should insist that everything get closed down? Or should we insist on our government, our county commissioners, our state telling everybody you have to wear a mask? Or truthfully, should we be telling our friends and relatives that are around us without a mask, why don't you have a mask on? I mean, I think that's a lot better than having a county commissioner tell anybody they need a mask. I tell people all the time when I see them, where's your mask? And because I think peer pressure has a lot to do with it. Now, this is a very interesting slide as of 2 o'clock this afternoon. So far in the state of Florida, 1.5 million people have been tested. Now, I just told you there's 23 million people living in Florida. So if 1.5 have been tested, that's around what, 7%, if we do the math? Out of everybody who's been tested, there have been 6% who test positive, meaning 94 out of every 100 people who've been tested in Florida so far have proven negative. And most people who are getting tested have been symptomatic. They've come to ERs, they've gone to urgent cares, or they've gone to drive-by either because they have a little symptomatology or because they're curious. Let's do the math again. 23 million people in Florida. As of 2 o'clock this afternoon, 1.5 million of them have been tested. 6% have tested positive. Is that increasing? Well, yes, that has increased. You can see right up here. A couple weeks ago, this wasn't 6%, this was 5%. Why is it increasing? Well, one thing you could say is because we're testing more people. But I could tell you why in my mind it's increasing, because in certain pockets where there's a lot more COVID in Palm Beach County, those pockets are being tested more heavily. I know that for a fact. And I know people say that's not just it, but I know that's for a fact. So yes, this is a bothersome number that there are more positives from the amount of people we're testing. Let's look at Palm Beach County. This is the amount of people in Palm Beach County who have been tested as of today at 2 o'clock, 119,000. There's 1.3 million people living in Palm Beach County. So a little bit less than 10% of our county people have been tested, of which a little less than 9% have tested positive. But again, look at this, that's rising. Why are we seeing more positive rate of testing now than we were seeing a few weeks ago? And it was down here, almost 4% of the tests. Again, a few reasons. I think people who were curious before and were unlikely to be positive made up a large pocket of this total people. And I think now it's more symptomatic people being tested, because as the months go by, people are a little bit less curious and are not willing to go stand in line or whatever. That's one. But let's be real. Part of it is because there's more spread. And there's more spread because people have taken their foot off the pedal. Let me give you an example. The fastest growing population with syphilis in the United States right now is in the HIV population of men who have sex with men. Why is that? Because men who have sex with men have avoided having safe sex like they were doing in the 80s and the 90s, because people have short memories and they're not seeing their friends die as much. So these numbers are a concern. Now, this breaks it all down for Palm Beach County. This is as of yesterday midnight, or as of this morning midnight. There have been about 10,506 cases in Palm Beach County. The mean age, look at the mean age, Okay, the median age is 44. Look at the amount of cases by day. Yes, it's rising. Look at the age by day. That's not rising. It's not rising in the elderly. When we say the elderly are more vulnerable, they're not more vulnerable to becoming infected. They breathe like the younger people breathe. They're more vulnerable to be doing badly if they get infected because they have less lung reserve and their immune system just by age is less than somebody who's younger. When you look at the race and ethnicity, this is just Palm Beach County of the cases. 42% so far as of this afternoon are white folks, 18% African American, 17% other, the majority of which are Hispanic. Okay, but Hispanic are also included in the population up here that's included under white. If you look at the deaths, 68% have occurred in what are described as white, 20% in the African American population, 8% in the other. Let's look at Palm Beach County outcomes for Florida residents. First, statewide, 14% hospitalized, same thing in Palm Beach County. 3% deaths in all Florida, 5% in Palm Beach County. Why is it higher in Palm Beach County? Because we have the eldest population in all Florida. Why does that surprise anybody? I've been asked that by the newspaper every other day. What are we doing wrong in Palm Beach County that the mortality is almost twice as high for the state? I said, we have a lot of old people here. You know, elderly people don't tend to retire in a lot of the counties. They come to Broward, Dade, and mostly Palm Beach County. Palm Beach County cases and facilities, long-term care made up 11%, correctional 3%. That's Palm Beach County as of today. To give you an example of testing positivity, okay, you can see the amount of people that are being tested every day, right? And as I told you, a lot more people were getting tested back here. Why are there almost half the amount getting tested here? Because a lot of the people who were curious back here aren't as curious, and most of the people getting tested here are people who are symptomatic. So therefore, you have to have a higher number of positives. Let's look at this compared to Broward County, where there's been almost the same amount of cases as Palm Beach County. Let's look at the hospitalizations. More hospitalizations in Broward County. I showed you before, it's about 11% in Palm Beach County. Let's look at the mortality, similar to Palm Beach County. They're not quite as old as we are. Look at the how it's made up. White folks, 49%, African Americans. Why is the African American population in Broward County seem to be more disproportionately infected? I don't know. I mean, a lot of people have their thought on it, but obviously there's an answer. There's a reason for it, as opposed to the other. And let's look at Dade County, which makes up the most cases in Florida, 25,000 cases. This is as of today. Again, the median age is pretty young, 47. The cases, 54% white, which includes Hispanic, right? Almost, right? African American, 16%. You would expect it to be more Hispanic in Dade County. There's a bigger Hispanic population. Hospitalizations, the same as here. Mortality, the same as here. Long-term care, the same as here. So then Martin County. Let's take a county that's a little bit north of us. 1,460 cases as of today. That's about 10% of what we've had. Look at the median age, even younger. Look how many hospitalizations, only 10%. Why did they only have 1% mortality? Well, the reason why they have 1% mortality is because they have a much younger population. Just go by the median age of people who are being infected. And you can see that this is heavily more white folks and African Americans than Hispanics for various reasons. So then how do we prevent this? Well, you know, you can't say this enough, right? Avoid close contact. Don't sneeze on people, and masks. Let's talk about masks for a minute, all right? But before I get to masks, I just want to make sure everybody understands sterilization, disinfectant, antiseptics. Sterilization means you've killed everything. If you want to sterilize a human being, you got to put them in 450 degrees Fahrenheit for 15 minutes. Well, obviously, that's not happening. If you want to antiseptically clean your hands, you have to have something that has 60% of alcohol, ethyl alcohol or more. Disinfectants are the same thing as antiseptics, but they're used on inanimate objects. You know, you wouldn't swallow Lysol, right? But you can gargle with Listerine if you want, and that does have some antiviral effect, just as ethyl alcohol does. Before we get to masks, we'll talk about treatment. What treatments are there? There's only one FDA EUA treatment, remdesivir. Everybody who gets admitted to the hospitals where I'm seeing consults gets on remdesivir the minute they get admitted, because by definition, if they're admitted, they're ill. And this is an antiviral medication that looks like it has some benefit, and the best chance of having a benefit is early on because it shuts down the virus. Once the virus has caused its effect and your immune system goes into play, it's not going to have an effect on the immune system. Now, you probably heard this past week out of Britain that it's been found that a common steroid, which we use in the hospital called Decadron or dexamethasone, seemed to have some great beneficial effect. Why is that? Because that helps cut down the inflammatory reaction to the virus that's harming your lungs. You've also heard about convalescent plasma, giving somebody antibodies from somebody who's recovered. Well, the truth is we're doing that with almost everybody who's admitted to the hospital. The problem is we're running out of convalescent plasma because one blood, which is where we get our convalescent plasma from, can only process so much. Do I have great hope for this? No, because when we look at passive immunity, giving antibodies, those are things like if you're traveling and you're worried about getting hepatitis A and you've never had a hepatitis A vaccine, you may get immune globulin for hepatitis A if you have only a short time before you travel and you don't have time for a vaccine. But we're giving you antibodies before you have the virus. Look at everybody with HIV has IgG antibodies, but they all still have HIV. And I can also tell you that by day 7 of infection, which is basically when people show up in the hospital with COVID, half of them already have antibodies. So I'm giving them antibodies to something they already have. So it sounds good. Is it really going to be the best thing? I don't think so. It has to be antivirals and anti-inflammatories. You know, there's a lot of controversy against hydroxychloroquine. That's become a political tool. What do I think? I think in vitro hydroxychloroquine has some antiviral activity. Does it turn into anything beneficial? There's no confirmed proof of that. What we do know is all the hoopla about it being cardiotoxic was a little bit phony, and the New England Journal of Medicine and the Lancet Journal withdrew those articles, retracted them because they were made up. And then, of course, if you watch enough breaking news, you can see that almost anything's going to be effective. So here somebody's talking about cocaine. What's the answer going to be? The answer is going to be a vaccine. The problem with a vaccine is it's very hard to get a vaccine that you can prove is going to be effective. It's very hard to get a vaccine where the vaccine, the treatment, the prevention is not worse than the disease. And then once you do have a vaccine that proves that it can produce effective immunity, and you do have a vaccine that proves that it's not harmful, you have to vaccinate a group of people and wait several months to several years before you can really statistically say that the people who got the vaccine were less likely to get infected than the people who didn't. Let me give you one closing example. The high-dose flu vaccine, which some of you may have gotten, which is indicated for people over 65, that vaccine's been around for a long time. And what the FDA did know was that the people who got that vaccine who were over 65 had higher levels of antibody. What they didn't know was that going to prove to mean that they would have less cases of influenza than compared to senior citizens who got the routine flu vaccine. And it took 4 years to say, yes, the higher dose antibodies turn into more protection. Now, there's going to be a whole host of vaccine trials out there. And I've been offered, have heard I do some clinical trials, that we may have one in Palm Beach County where we're going to be able to enroll 3,000 people. I'll be curious how many people are going to want to get the vaccine and be followed for 2 to 3 years. But hopefully, when there is an effective vaccine, it won't go the way of the flu vaccine. It won't go the way of the measles vaccine. And the people are going to be willing to step up and get this, because herd immunity is the only way we're going to really, really end this, as well as not counting on the commissioners or counting on the governor to tell somebody, hey, wear a mask and social distance and do the right thing. I think that's all of our job. I don't think it's our political leaders' job to do that. All right, I hope I didn't go over my time. Thanks for listening. I'm going to take that off the screen. Thank you.
Thank you so much, Dr. Bush.
Thank you so much, Dr. Bush.
You're welcome.
Let's see, questions. So there's a question about why does it matter if a positive case is a resident or a non-resident?
It really doesn't. I don't know why they do that data. They do that with all communicable diseases because I think they want to talk about, whether that person came down here from New York and should that be counted as a New York case or a Florida case. They really want to talk about when it comes to disease spread, was it likely acquired here in Florida versus somewhere else and came here via travel.
Okay, great. There was another question about earlier on azithromycin was being given to COVID patients. Can you explain what the rationale for that was? Why was it being given?
The same reason that we take people with chronic bronchitis and we tend to have them on azithromycin, because besides its quasi-effective antibacterial effect, it really doesn't have antiviral effect, but it seems to have a decent anti-inflammatory effect. The same way that statins, drugs like Lipitor, Zocor, have an anti-inflammatory effect. In fact, there are studies showing that people who are on chronic statins seem to do better with influenza, maybe because of the anti-inflammatory effect of the statin.
Okay. Let me see. Do you think there are a lot of false negatives in the testing?
Yes, I do. And the reason I think that is false negatives, meaning people get tested and they're not, and the test misses it. I think so, because I think a lot of it depends on how well it's being collected. And what I tell people, when they did your nasopharyngeal swab, if you didn't feel like you were choking, they didn't get in the right direction. So it depends on how well the sample is collected, how well it's transported, and then it really depends on which machine they're using. The one that's more rapid has a little bit less sensitivity than the one that's a little more sophisticated. So yes, I think there's a fair amount of false negatives. On the other hand, there's probably more false positives for the reason I said, that it can cross-react with other coronaviruses. And in a population where the prevalence is not very high, which is our population, then a lot of the tests won't really mean they have coronaviruses. Meaning out of the 91,000 cases in the state of Florida so far, a lot of them may not truly have coronavirus.
Okay. How soon after possible exposure is testing effective? And I'm not sure whether they mean the PCR or the antibody testing. So maybe
exactly. So it's been found that most people who get exposed who are going to have symptoms probably have detectable PCR by 5 or 7 days. The asymptomatic people are supposedly have the highest ability to detect their PCR 2 days before they become symptomatic. So I think it can become detectable anyway, 1 day after until you're symptomatic, but it's hard to say. The antibodies probably become positive at 97% of the time if you did get exposed by 14 days after exposure.
Okay. Question or concern about the dexamethasone. Do you think it's going to help with the symptoms, or will it reduce the body's ability to fight the virus?
Actually, steroids early on are more anti-inflammatory than they are immune modulating, meaning they're not going to hurt your immune system when it's used for the amount of time instead. In the study, it was only used for 10 days. So the goal there is to shut down the inflammatory response to the virus so that your lungs don't get damaged. Because it's your inflammatory response that's attacking the virus in your lungs, and your lungs become the collateral damage, and therefore you can't breathe.
2 more questions here. Do you think people that are sick with COVID but not sick enough to be hospitalized, it says benefit from self-pronation at home? I don't know if it means pronation or isolation.
No, so pronation basically means that we're taking people now, and we find that if they lie a certain time on their back and a certain time on their chest, that their oxygenation improves. And that's been proven in studies too. For people who are not symptomatic enough to be in the hospital, meaning they're oxygenating well, they're not symptomatically enough to need oxygen, I think that proning, meaning lying on your chest, is not going to make much difference.
Okay. And then what do you think about Rebecca Jones's statistics?
I think, everybody has an axe to grind. I think that, I'm in contact with the state surgeon general. He's an academic pediatrician from the University of Florida. He has said some things that go against what the state has said, and he still has his job. So he must, not be felt not to be reputable. I think that the statistics are accurate. Are they 100% accurate? No. Do I think they would be falsified? No, because that data that you saw up there I also go to the John Hopkins website, and they have almost matching numbers.
Great. I don't see any new questions. There's one. Is there inflammatory connection and greater ill effect in those who have environmental allergies versus those who do not, where allergies are an inflammatory action?
Yeah, not that it's been proven. It's more the ability to respond to the virus, which is immune defects, but not allergic defects.
Okay, wonderful. I don't see any more questions. If anybody has any, please put them in the chat in the next 10 to 15 seconds. 2 negatives on the same person are counted twice, while positives are counted once. Apparently Rebecca Jones said this.
Yeah, because positive tests are counted as positive. The negative ones are strictly being used by 2 negative because you can't move somebody or take them out of isolation to a nursing home. For people who aren't going to nursing homes, what the CDC guidelines are and what we follow is that if you tested positive and you were symptomatic, you can come out of isolation if it's been 10 days since the onset of your symptoms and at least 3 days since you have no fever and feel well. There's no repeat testing. And the reason for that is because when they looked at this, both in Singapore and the United States, even if you tested positive days and weeks later, that virus was not viable, meaning it was not actively replicating in you, that DNA that you're carrying in RNA that you're carrying in the back of your throat, and you're not contagious.
Great.
Well, let me just give one last thing. You're hearing about the surge in the hospitals and the ICUs. I could tell you that in Wellington, we have a 18-bed ICU, and there are 12 people who've been on a ventilator on there for 6 weeks. So it's not like the ICU is filling up because of new people coming in. It's because we can't move those 12 people out. Also, when you look at how many COVID patients are in the hospital, I have at least 10 people who are sitting there because I can't get 2 negative tests. Otherwise, they would have gone back to their long-term care facility, their nursing home or their ALF, but they can't because I can't get a negative test. And they may not test negative for a long time. So we're having attrition of people in the hospital, partly because we don't have subtraction of people who normally could leave the hospital.
Okay. There's one final comment, and I'd like you to address it because I've heard this myself as a physician too, that death certificates are, there's more death certificates that are being labeled as COVID because hospitals get more funding if they have COVID cases. Can you comment on that?
Well, hospitals do get more funding if they have COVID cases because right now the government is paying for uninsured people to physicians and hospitals. When people are, quote, deemed to be septic, it's a higher billing rate also. So it does benefit the hospital to list a death certificate as COVID. But remember, the death certificate is filled out by the independent private practitioner, not by the hospital. It's only the medical examiner or the physician who can fill out the death certificate. And unfortunately, death certificates historically are very inaccurate because you'll always see the first cause of death saying cardiopulmonary arrest, right? Well, that's the common cause, how everybody dies. And then it will be, say, secondary to, and COVID may be on there. For instance, if somebody stayed at home and they didn't come home in the hospital with their chest pain because they were afraid of COVID, and they did finally show up with their acute MI that they let go on for too long, and they happen to screen positive, they'll be listed as a COVID cause of death when that's really not their cause of death. They just happen to be an asymptomatic carrier, but they'll be counted as a cause of death. So there's a little bit of play in there for, you know, financial, political, and inaccuracy, why that happens.
Wonderful. Thank you so much, Dr. Bush. This was
Yeah, I'm
wonderful.
sorry for going over my time. I hope that wasn't too Monday.
I'm going to pass it on to Cindy. Can't hear you, Cindy.
So glad that we recorded this because you were amazingly quick and fast with your presentation, and I wanted to study a lot of your slides. They were very informative. So thank you so much, Dr. Bush.
You're welcome. Thanks for asking me.
At this point, I'm going to stop recording.
Okay.
And if anybody wants to stay behind and talk about other business, we can do so, but let me stop recording.